Hello again, everyone, to another episode of Resilient Health Radio. I'm your host, Dr. Darin Ingels, and joining me on the podcast today is my friend and colleague, Dr. Shilpa Sayana, who is a board-certified medical doctor in internal medicine and functional medicine, and actually practices not too far down the road from me in Sherman Oaks, California. So, Dr. Shilpa, thank you so much for joining me today.
Yeah, thank you so much for having me. I'm excited to be here.
Yeah, so I know, kind of, you're a functional medicine practitioner, and I know a big population of people you're working with are women.
Yeah,
And I think we were talking about before we got on, primarily, I think you said 35 kind of on up. And
right.
I know I see this in my practice, but I really want to talk with you today about, as women start to get older, and I'll let you define what older is. But a lot of things change as we get older. We're both men
Me
and women,
too.
but for women in particular, particularly as you start broaching that time of, perimenopause and menopause, there's just a lot of things going on with the body hormonally,
Yes,
emotionally, cognitively,
right.
which is why it seems like women, suffer a little bit more through that time period than men do,
Right.
given the same age. So, what is that kind of, what are some of the big features or the big things you see,
Yeah,
particularly as women get, we'll say over, 45, because that's
yeah.
about the time that women might be starting to enter perimenopause. What are some of the big overarching things that, women need to be thinking about with their health at that time period?
Yeah, I think, at that time period, there's so many things happening in your life as women. Your kids may be going to college, your older parents may be getting older. You may be reaching like a peak in your career and kind of thinking, is this it? So there's a lot of stressors that are happening. And I think it's something important to point out that the highest suicide rate for women in the United States is between 45 and 55.
Oh, wow.
But this is where women are actually so feeling so compelled where they're taking their own lives. So it's an important time where you really have to kind of see what's going on. And what we generally see happen is it is the entrance of perimenopause, menopause. And some women, this happens in your late 30s. And the common thing we find is like a super stressful event that just pushed them into perimenopause way too early. And that just means that your hormones start getting lower and lower. And when they go to the conventional medicine doctors, they might just dismiss them. And as an internist, I was taught nothing about perimenopause, menopause in all my training. It was something I had to kind of seek out on my own because it isn't something, and in conventional medicine, as you know, we're very reactive. Like, are
Right.
you dying? Is this something that's an ICD-10 code that's recognized you have diabetes or heart disease? And then we'll react. We don't think about it in functional medicine is what's optimal. Yeah, your hormones, first of all, nobody checks their hormones. As could hormones be a
Right.
big culprit to your symptoms? We just dismiss them and say, do you need Prozac? But perimenopause, menopause is not a disease. It's a natural state of transformation, and it's not a Prozac or an SSRI deficiency. So it's important for women first to check their hormones. Like go to a provider and can be your own primary care, but insist upon it. Work with someone who's willing to check and know when you should be checking your labs. Should it be right before your period if you're still having periods, or when in that time frame you should check? And I think a lot of conventional doctors just dismiss it because they just don't know when, they don't have that extra bit of training to know what to do about it. So I'd say the most important thing is to check your hormones. And this is something, you can really relate to. When I talk about hormones, I don't really mean just your sex hormones. I always liken it to the relationship of different hormones to the family dynamics. Think about your adrenal glands, which make your stress hormone, as the wise grandma. And think about the thyroid as a supporting mom. And think about the ovaries as a sensitive grandchild. And the ovaries are going to be sensitive to all that stress that grandma had, which are the adrenals. So sometimes if you just look upstream and do what you do, which is focus on nutrition and lifestyle and stress management, the adrenals get better, and hence the thyroid and ovaries improve. And a lot of times patients come to us not for hormones, but what are the natural alternatives to perimenopause and menopause they can do to improve their quality of life. And generally it's really looking upstream, what's happening to the adrenals and the thyroid, and we see your hormones get a little better, or at least your symptoms get better.
Yeah, I think people forget or maybe not aware that, all these hormones talk to each other. I think, when you go to your doctor, again, they think about just your thyroid or just your adrenals
Yes.
or just your estrogen, progesterone. And the reality is there's this very complicated concert
Correct.
going on in your body of how all these hormones are connected with each other.
Exactly. And you just have to understand the language. Like if you're understanding the conversation, then you know that, oh, yes, your doctor was right that these hormones look normal, but they don't look optimal. And a lot of it's just the range. Like, a lot of times people come to us and they're like, my doctor told me my testosterone levels were normal. And as you know, both men and women have
Right.
testosterone, but it's in the super low quartile of normal. Like if we gave them supplements or improved their gut health, or gave them some top testosterone, their numbers would improve markedly. And again, they don't have to, we're not trying to make them men, but it's like, how can we improve the hormones so they feel more vital and more vibrant? So it's really about find somebody who can check your labs and not dismiss you. And a big thing with hormones is what we look at is the gut. So a lot of times before we prescribe anybody hormones, or most of our work involves what is your gut doing? What's your gut microbiome and what's your gut lining? Because people who have a common condition called SIBO, small intestinal bacterial overgrowth, where they may have symptoms, they may not, maybe bloating, it may be nothing. But generally, people with SIBO don't process their estrogen very well. So if you're going to give them hormone, they may have an abnormal mammogram with more fibrocystic breast disease, or they may feel good, but just temporarily not feel good. So it's so important to check your gut and your liver, because you really need to make sure your liver is ready for tomorrow's prescription.
So, what would be some of your recommendations of what are some common blood tests, the hormones that people should ask their doctor to be checking for them?
Yeah,
And
but
what time of their cycle should they be checking it? Because it
yeah,
does matter whether you're in the first or
yes.
second half of your cycle, right?
Yeah. Yes, it does. And then we see like the people less than 35-ish usually come to us because they may have like period stopping prematurely or polycystic ovarian syndrome. And for those kind of women, it's important to check hormones not on birth control. Because when you're on birth control, it suppresses all your sex hormones. So ideally, if you could be off for a month to two. And if you can't be off, at least you can check your testosterone levels, your adrenals, and your thyroid. So generally, our prescriptions for hormones include your cortisol, AM cortisol, ideally before 10 a.m., and your DHEA, which is the mother hormone to your cortisol. And then on the thyroid and the supporting mom role, you want to just have a complete thyroid panel. As an internist, I was only taught to check TSH,
Right.
maybe feed T4, but what's your feed T3, which is your active thyroid? What's your thyroid antibodies? I would say the number one autoimmune disease we diagnose, which I'm sure is the same for you, is Hashimoto's, which
Right.
is an autoimmune thyroid condition. And once you have one autoimmune condition, you're 3 times more likely to get the next. So what's the canvas that you're building on that's allowing all these autoimmune diseases to occur and also to spread? So it's your thyroid complete panel, and then it's to check your sex hormone. So it's estradiol or estrogen, progesterone, testosterone, and then the one common lab I feel a lot of people just forget to test is your sex hormone binding globulin.
Mhm.
And
Right.
that's a protein that just kind of binds up all your free and available hormone, your testosterone. And so sometimes people come and they're like, I am on testosterone. My testosterone levels are really high or good, but I don't feel any different. And it's because of this one protein that just bound up all their testosterone, so they just can't feel it. And so in that kind of situation, it's so important to look at your gut health. And then the second thing is your toxic burden. So those are the hormones we check, but for every patient, they get autoimmune labs, inflammation labs, some nutrient labs, and then we really encourage them to test their gut health. And then the last thing we check is toxins. Our biggest thing, at least here in LA, is most people have high levels of mercury from sushi. It's a big common thing here. People love their sushi, and so mercury
All
is
that
generally
tuna.
all that tuna. And a lot of our patients don't detoxify well, or constipated. Patients are like, I go to the bathroom once every 3 days, and that's not normal. But they've gone to their GI doctor, and they're like, as long as you're pooping once, it's fine. Once a week, which
Well, we were talking before we jumped on here. You live very close to the Palisades, which, of course, we just went through this horrific fire, and we were trying to, help understand, how much toxic stuff is still there in and around the area. The wind was very bad at the time the fires were active, so all that stuff that was burning and the pollution got scattered for many, many miles. And I don't know that we know the full extent of how much it's impacting people who live in and around those areas. I mean, I think LA's always kind of had the reputation as a whole of being kind of a cesspool of toxins just because of the
it is.
pollution and the smog.
Yeah.
But now we've got this other layer of all the stuff, that burned with the Altadena fire, the Palisades fire.
Yeah.
I think for people living in the greater LA area, this is a real environmental risk that I don't know that we fully appreciate. And like you said, if you're someone who's not a
Right.
great detoxifier,
Yeah.
that just adds so much more to the body burden.
Completely. And I think for all our patients, we check genetics on most patients who are willing. We don't use 23andMe because it's concerned about privacy, but we do DNA Life, which is a company that allows us to look at your genetic profile. Do you detoxify well? Are you really prone to inflammation? And those kind of patients who've come from January to now, their labs have changed. Like their liver enzymes are slightly high, maybe not abnormal, but slightly high. I mean, repeating some of their toxic profiles, they have higher levels of cadmium, lead, and arsenic. And so we're really assuming it could be the fire. So I think it's important for your listeners to really understand, who are you? Like, what are you as a vessel that you came into the world with? What are your genes? Do your genes allow you to process toxins well? If they do, great. But I always joke around with my patients who have methylation issues like MTHFR, COMT genes, where you can't detoxify well, that maybe in the next 2000 years, patients like that will have gills to really process these toxins. Because at this point, our level of toxic burden, especially in LA, that was already the most polluted city before the fires, is just skyrocketed. And I haven't evolved quick enough to actually metabolize these toxins. So a lot of patients, I'm like, try and do some basic things. Are you sweating, like non-exertional sweating? Do you have a sauna at home? Are you doing and some of my patients are like super A+ students. They're like, I'm really hitting the gym hard and working out hard, but that's not the intention. It's how can you not push your adrenals, but how can you just naturally try and sweat more? And you detoxify by pooping, peeing, and sweating. So how can you push those pathways? But even trying to eat more anti-inflammatory food, I think the one thing I have seen a lot with women in this perimenopause, menopause phase is they have no time for themselves. Like nobody's saying no. They're like, okay, I'm going to take care of my parents. I'm going to take care of my kids. I'm going to do my presentation for my boss. And they're not setting that time. Like, what's my self-care time? How am I protecting my cortisol so that I'm not always having these cortisol spikes? And that's the one thing. What determines somebody to go into perimenopause at 38 versus 48? And I think a lot of it is how they process stress. Because if you're processing stress well, your cortisol doesn't have that ability to eat up progesterone. It's going to leave your progesterone alone. So you naturally and gracefully go into menopause.
Well, you mentioned it earlier, and I want to reiterate the point because I
Yeah.
think it's important. When you talk about reference range on labs, again, they don't tell you what's optimal. They just tell you what people have. And I'll just use testosterone as an example
Yeah.
because we've seen, particularly young men are getting lower and lower testosterones. Therefore, the reference range, I mean, if you look at Quest or LabCorp, I think the reference range is
Yes.
like 200 to 900. I mean, it's this
Yes.
very broad, wide range. And that's a big difference. I mean, that's the difference. I'm going to give you $1 or $100.
Exactly.
So, I think the medical community as a whole aren't really looking at the hormones. Again, what is really optimal? Where should your levels be? And, is the reference range just reflecting what people have, not
Right.
necessarily it's optimal? And, how do we best, try to correct that problem so that people really are getting the optimal levels? And I know this sometimes becomes a really sticky point with other practitioners because they'll say, well, why are you giving this someone potentially hormone replacement? They've got normal levels on their blood test. I'm like, yeah, but normal is all relative, right?
Exactly. It so is. And now you would ask me the question as to when to test. And sometimes when you test at the wrong time in your cycle, it can look relatively normal. But so for women in perimenopause who are actually menstruating, we want to check on mid-luteal phase. So the day 19 to 23 of a 28-day cycle. And the main thing we're looking at is progesterone, because that's the first hormone that starts to go down. But yeah, my conventional colleagues are like, why are you even testing? Or they will test and they'll just test it a random day, or they'll do it on day like 6 or 7 and their progesterone is 0 because it should be 0 during that time. And so it's important to know again when to test and to understand the labs, because if and you as a smart human can just look at those labs and say, oh, my vitamin D is supposed to be between 30 and 100 and my doctor said it's normal and it's 30. That isn't normal. So
Right.
that's really important, I think, to really make sure that you're working with the right practice that's actually willing to look deeper and not dismiss you. Because I think a lot of people think it must be in my head. It can't really be real.
I know. I feel like I spend a lot of time with my patients looking at labs they've had done over the last several years where some doctor told them everything was fine. And we go back and it's like, well, your ferritin's 19, you're iron deficient, your TSH is 3.7, you're
Exactly.
hypothyroid because it was
Right.
in the normal range. So
Yeah.
I think, the advantage of working with someone like you and I, functional medicine, naturopathic
Yeah.
trained doctors, is that
Mhm.
we're reading between the lines and again trying to help figure out for you what's really optimal and not necessarily what just falls in
Yeah.
that very broad reference range.
And at times it could take really like simple solutions, just like trying to make sure you're prioritizing sleep, some basic herbs for your thyroid to get you feeling really good. And a lot of times patients are like, I wish I'd come to you earlier, or I wish I knew functional medicine existed, or all some sort of alternative integrative practice existed because I've suffered for so long. And that's what I see with my 45, 50-year-old patients. They're like, wow, after coming and working with you guys, I feel like I've never felt this good. And it's sad that we don't have, it shouldn't just be naturopathic medicine, functional medicine, internal medicine. It should just be good medicine where we look deeply and just give them the appropriate time and care and educate them and partner with them that, this is what it could be. What's preventing you from getting there?
I want to shift gears a little bit, and along with the hormonal changes that happen, there's also the shift in the immune system. Can you talk a little bit about, the kind of immune changes and sometimes autoimmune things that happen as women kind of cross that threshold as well?
Completely. And once we start seeing women who are entering the perimenopause decade, we start seeing a threefold increase in autoimmune diseases generally. And this is something probably a lot of women don't even realize is happening. They're like, oh, I just kind of feel more achy, or I have joint pain. I just must be getting older. But the doctor is not checking, again, because we're so reactive in conventional medicine, not checking autoimmune markers like an ANA or an ESR. Those are the two, ANA, ESR, and probably thyroid antibodies are the most common autoimmune markers we check. And sometimes when your ANA is very low, like normal is zero is negative, and then the lowest level are 1 to 40 and 1 to 80, and they ask their primary care that, and they just can get dismissed. So like, it's just very low. It's common as you age. If you start, it's not lupus, so it's not, you don't have to do anything about it. But again, if you have one autoimmune marker showing up, it's more likely for you to have others. And commonly, without that estrogen, which really does help modulate your immune system, these autoimmune markers just keep going up. And a lot of times for women in this decade is a very stressful decade and a lonely decade. So I think we need to all be reaching out to our sisters and friends in this 45 to 55 range, especially, and make sure that they have support and community, because diseases are happening that they probably are completely unaware of.
Yeah. Are there specific strategies that you can recommend of helping manage, what is it do you think that's driving some of this autoimmune disposition? Why are we seeing it happen kind of in those mid 40s to mid 50s?
Yeah,
Is it
so I think that a
hormonal
couple of
shift or, what do you think's going on?
Yeah, I think there are a couple of reasons. First of all, it's probably been you're just coming out of your 30s, which has been a time of child rearing, just busy, busy, busyness and high stress. So that cortisol has been eating up your progesterone and pushing you more into perimenopause, menopause. But what's happening like foundationally is your body doesn't know the difference between you being chased by a tiger and you having just a ton of things on your plate. And so each time you get the stressful call from your boss or have to go be stuck in LA traffic picking up your kids, your cortisol spikes. And that in essence is a pro-inflammatory state. And if you're getting chased by the tiger, you get eaten or you get saved, and that's it. But this constant stressors that I see women especially bear the brunt of in our communities and in these decades, and they don't have any time for self-care or to do much for themselves. And this is where that chronically high cortisol leads to high states of inflammation that's dysregulated. And it's this dysregulated piece of inflammation that is the canvas for all autoimmune disease, heart disease, cancers, and inflammation that really needs to be measured and looked at preventatively, not just in a reactive fashion.
The other thing I see a lot too is changes in like blood sugar, cholesterol. what else is shifting metabolically that we start to see these
Right.
changes? Because again, I see
Yeah,
people who've never had a cholesterol issue or blood sugar
correct.
issue their whole life. Now all of a sudden, cholesterol kind
Yeah,
of goes up, their blood sugar spiking, and
exactly. Yeah, and a lot of women come in, they're like, I had a completely normal physical last year, but my primary care told me I need metformin and Lipitor. It's like suddenly, and I'm like, no, this isn't a sudden. And you're like, I haven't changed my diet. If anything, I've gotten more fitter and choosing better things to eat. But this is such a common thing to see where your cholesterol starts to spike and your blood sugar starts to spike. So one thing is in this inflammation that is increasing. And the second thing is as you're going into your 40s, your bones are kind of demineralizing. And so more toxins are being released into your bloodstream, impacting your liver. And your liver is the organ that needs to process good cholesterol. And if it's so busy dealing with a higher toxic burden, it's distracted from making that better cholesterol. Same thing with your blood sugar. If you've had chronic levels of maybe slightly increased blood sugar, now your cortisol's high, your inflammation is high, it's going to push up your insulin. And insulin is the hormone that brings down your blood sugar. But if your blood sugar is constantly a little bit high and high, you get insulin resistant, and then you suddenly now have prediabetes. So I think a lot of it has to do with what's happening with your bone health, what's happening with your grandmother hormone, which is your adrenals, what's happening in your cortisol that puts us into this pro-inflammatory state that not only impacts autoimmune, but things like metabolic markers, cholesterol and blood sugar. And it isn't about just being on Ozempic or Monjaro. It's, those medications have their space, but it isn't just a Band-Aid solution.
yeah, I wrote a book on cholesterol when I was a medical student, now going on almost 30 years ago. And
Wow.
it's really interesting that, I think the conversation around cholesterol has shifted a lot, certainly in the last, well, maybe say 5 years. And, for years and years and years, we preached about how horrible cholesterol is and you've got to
Right.
get down. And I know most cardiologists in this country want your total cholesterol under 200. They want your
Yeah,
LDL under 100. And
right.
again, the reference range for the United States is completely different than the rest of the
It
world.
is.
And so,
Exactly.
what are your thoughts on the whole
Yeah.
cholesterol
Yeah. I
debate right
think we need cholesterol, like cholesterol. If you look at the teratogenesis pathway, cholesterol is the mother, the root hormone that feed or root substrate that feeds all our hormones, whether it's DHEA, progesterone, cortisol, testosterone. So we need enough cholesterol. And for a lot of, the biggest cause of death in women above 50 is heart disease. And it's so, and I think women are get scared when they go to their primary and suddenly things are increasing. They're like, get on metformin and get on Lipitor. Like, am I at risk for heart disease? So we have a lot of women do a coronary calcium score above 15 because we really are trying to understand what is your disease burden. Is there plaque in there? Is there inflammation? But why are we so concerned about cholesterol? Is the end point is a heart attack. Are they at risk for a heart attack? But heart disease is not just a blockage of too much cholesterol. It's an inflammatory condition. So
right.
when your heart vessels are damaged by inflammation, it's your body's response to come and make a blood clot, and that's what a heart attack is. It's not that there's just too much cholesterol or too much blood sugar in your system, but if you can lower your global inflammation, you're less likely to have a heart attack.
Yeah, it's interesting. I read this recently, and I can't remember who posted it, so correct me. It might not
Yeah,
be accurate, but I know that total cholesterol used to be much higher. The
yeah,
reference was that at one point it was 400, then they
right.
dropped it down to 300. Now it's down to
Yeah,
200. So there was clearly a time in
yeah,
history where cholesterols were naturally higher. But again, I think the evidence that cholesterol being the really the
yeah,
inciting factor of heart attack and stroke, it's just not true. Like I said, it's the
yeah,
inflammation in the blood vessel, independent of whether your cholesterol might be lower or higher. And again,
yeah,
we know that oxidized LDL itself can be damaging to the inside of the blood vessels. So why don't just
yeah,
look at oxidized LDL as a
right.
biomarker versus your whole kind of lipid panel?
Yeah.
I don't know why we haven't shifted that, but I was
And I
talking
think
with
that's the problem. Yeah.
I was talking with a researcher out in Temecula who studies neurodegenerative disease, and his comment, it goes, as a researcher, actually, total cholesterol probably should be at least 250. Just
Wow.
because what happens, and we're seeing this in some of the studies on people on statin drugs, is we're starting to see signs of early dementia because your brain's a
Right.
big blob of fat. Cholesterol is the backbone for making a lot of your fatty
Yeah.
membranes. So are we selectively starving your brain the longer you're on a statin drug
Right.
in the effort to reduce your risk of heart attack and stroke? Are we
Exactly.
now sacrificing your cognitive function
Right.
by, starving the brain of that necessary?
Right, or your hormones. I took my dad maybe 2 years ago to a really good cardiologist here in LA, a kind, renowned cardiologist, and my dad's cholesterol is super low, like his total cholesterol is 160. And he recommended that my dad get on a statin. And I was like, no, he has a family history of dementia. And he brought out the study from Australia that said this is debunked, with that low statins, lowering your cholesterol isn't associated with dementia. But I was like, it's one study that, and it wasn't a very well done study. But the power and the belief in the statin is so powerful for
Yeah,
cardiologists that it's very difficult to even argue against. But 60 to 80% of people who have heart attacks have normal cholesterol.
right.
So is it really to do with cholesterol? And I think what's disheartening, and as a very optimistic medical student, it would be hard for me to even fathom, but as I've aged, I've gotten a little bit more aware of the world. There's a great book called Sickening, talking about like the economics of medicine and how
Yeah.
so many people who write these cardiology recommendations have ties with the pharmaceutical industry. So
Yeah.
it's important to know what's the level of disease rather than just treating a number. And I don't think cholesterol is the bad guy.
I agree. So, for someone who might be considering going on hormone replacement, are there things that mostly women, because that's most of your practice, and some men should be thinking about before starting this therapy?
Yes, we have about 80% women, and the rest are kind of the husbands of these women or sons. But I think the biggest thing in terms of thinking of hormones, first of all, you want to start ideally before 60, because there's some data if you start after 60, it may not be safe for you. But starting it early when you're going through the perimenopause, menopause time, I think what's important is to check your hormones, because in some of the conventional doctors who do give you just estrogen, progesterone right away, they're not giving you, you're not personalizing it. Like how much estrogen do you need specifically,
Right.
or progesterone do you need before just giving you that? And we start with a layered approach. So we start first with whichever hormone is the lowest, generally progesterone or maybe testosterone. If you have a uterus, you need to get the estrogen with progesterone to protect that uterus. But generally start with the hormone that's the lowest and try to go with the minimal dose that you need to feel better or for your labs to look better. So I wouldn't say do all the hormones as we do, and don't also do that same dose for every single woman, because each woman is different epigenetically, trauma related or inflammatory. So really try and dial it to what's happening in that specific woman. And I would say the other most important thing, and before considering hormones, is test your gut. And just make sure your gut can tolerate these hormones, because the gut's really the biggest organ system involved in processing these metabolites.
Yeah. Is there a specific gut test that you
Yeah,
favor?
we do a few. We do a SIBO breath test, and then we do the Genova's GI effects quite a bit. And then sometimes with patients, we can get away with doing their like NutriVal test that does have a gut section. But generally, we do the SIBO breath test in most women who are thinking about hormones. I'd say 80%, 80 to 90% of them test positive. And then when we do, or if they come in on hormones and having side effects, we definitely test their gut and they end up having SIBO, and treating that really improves their tolerability of the hormone replacement. I think it's just the liver. The liver is now able to kind of process these hormones, because the liver is the organ that processes everything.
Well, I like the way that you synthesize all this, that again, it's not just one little faction of your health. Again, we got to look at the hormones and the gut health and your detox pathways and your genetics and your environment. I think this speaks to the beauty of functional medicine. It's really stepping back and looking at you as the individual and what is it that's unique to you, that what need do we have to meet so that your body functions as optimally as it can, which is going to be potentially very different than your neighbor down the street or your parent or grandparent and so forth. So, we just have to recognize that we're all individuals and need to be treated as such.
Yeah, and I would say just a quick story. Just last week I had a patient who had she'd been on hormones, but she couldn't tolerate estrogen. She just couldn't. She was like, I really need it. I'm having all these hot flashes and symptoms. And what we found in her, she'd had some mold exposure, but her mold test showed very high levels of Zeleron, which is a mycotoxin that mimics estrogen.
Yeah.
And the the one science group that has the most impact on this on this mycotoxin is the husbandry industry, because they use Celeron to help chickens and animals go into early puberty because it's an
Oh,
estrogen mimicker. So once we like detoxified her with her mycotoxin, she's much more capable of tolerating estrogen. So it's about looking, who are you? What do you have now? Can you tolerate some of these things that you have deficiencies in? And just making sure, I think the biggest thing with all functional medicine, which I think is beautiful, is being heard.
absolutely. Well, we know that gaslighting has been a ongoing problem, I think, particularly for women for quite some time, and the fact that it's being recognized more. But I was told, and I think you were probably told by some wise doctor in school, listen to your patients. I mean, they'll tell you what's wrong with them.
Completely. And that's why all our intakes are 2 hour longs. Like we just have to get the story, like what happened to you? And there's so much trauma with so many people that's impacted their whole neurotransmitter hormonal cascade that has to be understood.
Well, I know that you just work with people in California, but for those tuning in who happen to be California residents, where's the best place that someone can find you?
Yeah, probably the easiest place is our website. Once on our homepage, we have, work with us, and there's a discovery call link, and it's just if you could talk to an onboarding coordinator for 30 minutes, just explain what you have, see if we're the right practice for you. We have something as simple as a lab consult where you just order your labs, your doctor won't order, and you can meet with us, or something that's more involved, like a program or a membership where you work with us to solve a deeper issue.
All right. Well, we'll post the link to your website so the
Thank
people want to
you.
touch base with you, they'll have an easy way to access that. And again, I think this has been a really useful conversation, particularly for women who are getting to that stage of life where perimenopause is either already there or around the corner, and just to be mindful of all these different things that can be done as you're going through that stage of life to really help you feel your best.
Absolutely. Thank you so much for having me.
Okay. Thanks, Dr. Shilpa.
Thank you again.